Hello, everyone, and welcome. We will begin in about 2 minutes as we wait for our audience to join. I see lots of people coming in right now. We'll do about another 30 seconds and we'll go ahead and begin. Welcome, everyone, and thank you for joining Unislink today for our webinar on how to implement CPT code G2211 in your practice. We're excited to have you with us. Before we begin, and I turn it over to our Director of Dedicated Credentialing, Pat O'Sullivan, to introduce our expert speaker, I just wanted to touch on a few housekeeping items. We will welcome all your questions. Please feel free to type them into the Q&A chat throughout the session, and we will keep track. If we run out of time, we will follow up with answers after the webinar. We will also be sending out a link to the webinar replay. Please feel free to share that with your colleagues as well. As a live attendee, we will also be sending you a free sample G2211 policy to help you create internal guidelines for your practice. And now I'll turn it over to Pat to introduce our speaker.
Good afternoon, everyone. My name is Pat O'Sullivan, as Gina mentioned, and our speaker, highly esteemed, Sonda Quincy, owns Coding Advantage, and I always joked about Sonda has more initials after her name than I have in my name, and actually I've counted, she has 16 more initials than I have in my name. She has after for all her certifications. She's an educator. She does audits. She's known as a coding guru all over, I know for sure, all over Ohio. Hospitals hire Sonda to do audits and also educate their staffs. So really excited that Sonda was able to join to actually do the seminar, the webinar today. And so I'll turn it over to Sonda. She'll tell you a little bit about herself, but this is a really important coding webinar that we're going to present to you. Thank you so much.
Thanks, Pat. So I am literally excited to be here because I just like to talk. Many people know me, know that I am not at a loss for words. Today, we're going to be talking about unlocking additional reimbursement in G2211. I think this code still is out there with a lot less information than even when they started. And it's important for us to validate everything that comes through about it so that you can get reimbursed. This is a valid code. It's a Medicare code, but some of the carriers are following suit. And it's important to know that you can use it. I don't want anyone to feel stifled that might not apply to us, that might not be our specialty. We shouldn't get that. It's too ambiguity. There's too much ambiguity around it. It's risky. Today, we're going to make you feel more comfortable about it so that you can start to implement it. So I am going to do just a little slide on myself, and I like to do it more on just the person. Yes, I do have a lot of credentials or symbols after my name. That was a lot of years of hard work in terms of certifications, but I have a huge passion about the healthcare industry, how we approach coding, billing, and documentation. I think that needs to change. I think we're on the verge of changing that. I think that we've been through the wave of, where we're documenting by hand, then we're documenting in electronic health records, and that's just getting just so crazy that we have to start backing down and making changes as well. But I have been in the business 35, 40 years. I know that makes me older. That's true. But outside, I really love running Spartan races. I don't know if any of you on here are fellow Spartans or CrossFitters. It's just something I like to do. And considering, running your own business and what we've got to deal with in healthcare, this is a total out for me of lifting weights and running and what have you. But I encourage all of you to continue with not only dealing with healthcare, but dealing with your own healthcare and making sure that you're there to support all of these providers who need our help to get reimbursed these days to stay in business and take care of patients. We really just need to talk about that. So before we get started in the whole, presentation about G2211, I'd love to do a poll. Everyone needs to filter in here and take this, see if this little quiz in regards to what you know about G2211. Just base it on what you know so far. There's no right or wrong answer here. Just give us what you think. We'll give a little few minutes for this to filter through everybody. It's a quick click. Just let us know what you think applies here. It'll be interesting to see where our most answered question lands. Okay, just give you a couple more seconds.
We have about 30% of the audience that needs to contribute here, and then we can end the poll.
Awesome. Come on, guys. Everyone on here, we'd love to see where you're at with your knowledge on G2211. I mean, you're here to learn more today, so don't feel like you have to have the absolute answer.
And by the way,
hopefully we'll get to that.
It's anonymous, so we don't know who chose which answer.
Yes, it's totally anonymous.
We're close, Sonda. I think, can you see those results on the screen so far?
I cannot.
Okay, I am going to read you the answer so far. Out of the answers, it looks like the winner is yes, because the patient requires ongoing management, and about 56% of the people answered to yes to that question. 1 and 2 were a tie at 19%. So yes, because the patient has a chronic condition, or no, because there is no additional complexity or resource. So the first 2 were tied at 19%, but the big winner was the third answer. Yes, because the patient requires ongoing management.
All right. Well, that's fantastic. And what I do want to commend you on is that you made a choice, right? So I think that's what's important here is, yes, the patient does have a chronic condition. Now, we're looking at an excerpt of notes, right? Because I didn't really go into it. We don't know if the patient's actually been a train wreck and just happens to be stable at this encounter. We don't know if they're on a myriad of polypharmacy in order to manage this, and that's rough for the provider as well. Honestly, we didn't give you, it's a trick question. We didn't give you enough information, but the fact that you started to gravitate towards C is a really good sign, because this patient requires a relationship with their provider to manage this. And again, we don't have any documentation sitting in front of us, and I didn't give you the full view of what a note would look like. But yeah, this is the things we have to think about when we think about, is G2211 for your office, or for, in what ways do we want to use this? All right, let's move on. This disclaimer, okay, it is meant to be funny. I am not a medical doctor, which just means none of us are. Although unless you're on and you are a doc, and good for you for jumping on. But what we're saying is, we want to be very careful on how we deal with the clinical judgment piece. It is up to our providers to decide what is serious and complex, or what makes a continued relationship. We're here to help them say, how do you demonstrate that in documentation, so that when, as a practice, as an organization, when we send it out, that we're comfortable doing it. So just basically saying trust, but validate. When you have someone giving you a webinar, a seminar, it's always important. And for everyone listening, the frequently asked questions for G2211 just came out in the last few days. So hot off the presses. We can probably include that link or something later on in the materials, Gina. This was a help to even further define it. but I don't think you're not going to be lacking once you have, we walk through this webinar. So we're breaking it down as concept, right? We all know the code, G2211. It's to represent a relationship. We've all seen it come out. There's been a lot. If you follow a lot of healthcare companies and consultants, there's a lot out there about this code. And we try to do that because we want providers to gain revenue. So there's always this, what we'll call sweet spot. We need to be billing this because it's a valid code and it's a valid reason to reimburse providers. And then we don't want where we have providers just going, just put G2211 on everything and I don't really care what it means. There's somewhere in between where you can design this in your organization to be compliant, to get the extra dollars you need. And Lord knows, money just continues to get cut with Medicare fee schedule, and we need ways to make that up so that the revenue keeps flowing into the office. So I want to make sure everyone on here becomes a superstar on how to build G2211, how to make sure it's documented, how to monitor it, when to worry about it, and when not to. All right. So let's talk about the definition. These are all from CMS, right? You can look on many of the MACs websites, and MACs, we mean the Medicare Administrative Contractor, and in Ohio is CGS, but they mostly defer to straight CMS for all of their definitions right now for this code. It's visit complexity. It's the inherent need in the evaluation management process. It is for providers who are continuing on a focal point with that patient who is in constant need of services. And constant need of services is they have a process. They have a chronic condition. They might, have 2 or more. There is no correlation to how many they need. It's no correlation to anything other than what's defined here. And notice in the definition, because I think this is super important, continued focal point of all needed healthcare services and or medical care services that are part of ongoing related to a patient's single serious condition or complex condition. So I think that it's important when we see an and or there, that is part of the physician's, nurse practitioner's, PA, the person doing the evaluation management's decision on what the word serious means. Now, we're going to break that down. I'm going to give you some ideas. We're going to put guardrails around that today. So just listen in on that. It is an add-on code. So it goes on a parent code. If you've not heard this terminology used, the parent codes would be the outpatient E&Ms. So it would be 99202 through 99205. And also 99212 through 99215. There isn't any correlation of which one to use that on, because really what you're doing is you have a medically necessary evaluation and management, which might be a 99213 and 99214, doesn't matter. Then you would do the add-on code. And yes, when you establish the relationship with the patient, when we're talking about a patient, that G2211 can continue on with that patient every time they see you. There are reasons why we wouldn't add on the G2211, and we're going to talk about that as well. So again, let's talk about why in the world was this even created? Well, it's supposed to account for some of the unseen cost or not talked about groups. So a provider sees a patient, and we think of that in concrete. When we're dealing with management, we think of that in concrete cost resource-wise, what it takes to see a patient, getting them scheduled, getting them in, taking the time to see them, how long were they in the office, and some of the follow-up. But that really isn't anything we can quantify with dollar value on the outside of that relationship with the patient, between the provider and the patient, and what it takes that provider to think about, okay, yeah, they're here for a sinus infection, but I have them on these 3 medications, so I can't give them this, I can't give them that cough medicine, or there's more to it than just in and out. And I think that we discount that in terms of our providers' knowledge, their relationship with our patients, and things like that. So this is really to pick up that nuance and pay the provider additional funds. So think of it, we think of it as an add-on code. We think of it as risky billing. But when you're thinking about this, the intent of this code was to pay the physicians a little more money when they have established that relationship and things happen between visits that we're not capturing. So it's more of a enhanced payment. Would you? And listen, we could go as far as saying value-based, right? It's not straight value-based based on what we know value-based is, but it's a value pickup for the provider to be paid for that relationship and the time they put into knowing their patient. That's what this code is. So I think that sometimes is a misnomer, and we all come out and go, okay, everybody's billing G2211. This is a tragedy. This is going to be a fraudulent thing. Well, there's always that, but I'm going to tell you that likely we're talking about 2 to 3% of people approaching this as we're just going to slap this on every code, where we have most people just taking the conservative approach. There's somewhere in between, and we need you to be there because we definitely want more revenue in these offices to support staff and resources and things that it takes to do that. So again, that overview of the longitudinal relationship, and I have looked this up in Webster's dictionary. I have looked this up as far as CMS is concerned. Many of us are looking this up going, well, what did they mean by longitudinal? I mean, why would they use such a word? Well, I don't know. Have you not ever dealt with Medicare? Sometimes it just doesn't make sense. What they really just mean is it's a long period of time. Now, when I say that, you know that the rule says you can still bill it with a new patient, okay? And the reason behind that is if you have the expectation of having that long-term relationship, you're allowed to bill the code. There's nothing wrong with it. So when you go to decide your policies and a nice little, we're giving you a sample policy to start with, something like a seed just to keep you going, something to work off of. That's for showing up. And that should at least establish for you how you can write that and put the guardrails in for your providers. There's times when we know a patient makes an appointment, they're a new patient, they don't really have a lot of problems going on. They're sick. Maybe they just found out they have COVID. Maybe they have a sinus infection. They're trying to establish care, but there's no indication that they have this big deal going on in terms of chronic conditions or serious conditions at that moment. So it probably wouldn't be valid. You just really have to use common sense the best way that you can. All right, more about that. So they did release this prior to 2024, by the way. I think if you are all were paying attention to Medicare fee schedule updates, you probably saw G2211 come out prior, but the implementation piece of it actually being on the paid, right, where they put a value to it, was in 2024. So the code, sometimes codes come out on the Medicare fee schedule and they're testing them and they say, well, here's a code, but we don't really, we're going to delay that implementation process. We know it's something we want to do, but they didn't create guidelines around it and give the mechanisms. But since 2024, January, you should be able to bill this and add it to Medicare, Medicare Advantage, and commercial. And there's a slide about that in terms of the way the billing goes that we can really break that down for you in terms of your revenue cycle and tracking that. And I love I can see the Q&A. I love that you're engaged. So are we seeing commercial payers in the market paying for this? Yes, but when we get to that slide, you'll see a couple of them that are starting to take a stand. But what you want to watch, and with everybody we know, when there's a policy, when you say something like United Healthcare, we have to think of United Healthcare Medicare part, United Healthcare commercial piece, and United Healthcare Medicaid. So I'm going to break that down. But yes, we are seeing commercial carriers pay for the G2211. And you got to test your market and see where they're at. But I do, like I said, I have a slide that breaks it down with 2 carriers recently that came out with some policies. And I'm going to explain how that should look in your revenue cycle. Yeah, the physician reimbursement historically placed a higher value on procedures. So again, that bullet, what we're talking about there is that when we see value in terms of Medicare fee schedule, where we see the dollar value going up, if any of you follow this, but to keep your minds on this, a lot of times for surgical procedures, the value will continue to go up. But if you're ever watching the news, it seems like the evaluation and management keep going down. Every year we're cut a certain percentage, and every year we're like, how in the world are we going to handle this when we actually, you know, don't know what's going to happen? Well, that's why they came along with these codes. And there are other codes, and I would love to come back at some time with even more codes that could possibly, you know, bring to our primary care providers. And by the way, this isn't limited to primary care, but a lot of the primary care are struggling the most in terms because most of their bread and butter is evaluation and management. So in that case, they're trying to bring mechanisms here to increase the value of the services they're providing. And again, the difference is, as we said, it's an add-on. You can't bill it alone. So that's important. All right. So let's going into the billing piece of it. All right. So this is we'll call this the money slide. And we'll have our little conversation about it. Right now in the state of Ohio. And if you're, you know, listening and you happen to be in another state, that you need to look that up. It's usually around $16 is a national average. So we're pretty close to that here in Ohio. And this is, again, $15 more every visit. I mean, we really need to think about this. You go, oh, $15, is it really worth the risk? Yes. If you know how to implement this the right way, like I said, we're giving you some tools here from being on here with us, and it's a start. It's a little policy. You can bring it to your providers and say, how are we going to implement this where we feel safe? We feel comfortable. The risk is not there, but the value is, and we need $15 more, $16 more per visit. Definitely want to do that. So again, definition is there. I put it in more than one slide. We'll just say it again. It's a continual focal point. It's all needed service. This is like a primary care, but I have seen this in I've seen this lifted off very well in 2 other specialties. There are plenty. And if we talked your specialty, and at the end, if we have some time for Q&A and you want to throw out your specialty and what you're thinking of, we can definitely talk about that. But endocrine, right? Diabetics, this is a serious focal point. And, you know, sometimes this is what they've got to add to theirs. And neurology, when they have a serious medical, that neurologist has a focal point on that patient. So although we talk primary care and we're supportive of our primary care providers, if you are a specialist, you shouldn't shy away from this. You have to think about your patient presentation, think about how many that would affect. There are ways to go about this to think of it strategically in your specialty. Who can bill for it? Okay, well, that's important, right? Anyone who is eligible to bill an evaluation and management code is eligible to bill this. So we're saying that, you know, you're a dietitian, a nutritionist, unfortunately, even if you're a social worker or somebody like that this code is not for you. This is more medical side, not behavioral, not nutritional, not all the other wonderful things we do with our patients. This is on the medical side for those serious conditions that we deal with. Again, I gave you the codes. In the frequently asked questions that just came out, it was clarified. It doesn't matter where you use those codes. And the reason that had to come out is there was question about outpatient hospital based providers, you know, the place of service 19 or 22 in addition to our office. And it is clear that they are allowed to bill for that. It is the extra dollar. So we want to make sure that everyone knows that. It doesn't matter where these codes are used. It's place of service 19, place of service 22 or 11. It's just this subset. Unfortunately, it is not added to nursing home or anything like that. So these are the codes that you can use. And then the place of service does vary a little bit. And one of the things we do have to think about, and we always have to think about, it's subject to deductibles, coinsurance, all those types of things. So with our patients, we do need to be aware that they could see an additional rate come about in their bill, and we just need to be prepared for that. All right, let's like do some math. Not that math that's my specialty. It's not. But for those of you who really like doing the math, we're going to use $16 as the rate because, who wants to multiply by $15.92? All right, let's say your provider sees about 25 patients a day, and about 80% are that would qualify. And we're just taking a random number here. That means you have 20 patients at $16 extra, $320 a day. So let's multiply that by a conservative guy or gal doc that works 3 days a week, $960 extra dollars a week. They work about 48 weeks in a year, give or take, depending on if they're a traveler. An additional $46,000 in revenue. Why leave that on the table? Why? You shouldn't. Even if we said, let's take the one about works a 4-day week, $1,280 for that week times the 48 weeks is another $61,000. You know what that could represent? Another resource in your office that you're so sadly in need of, right? And let's take a group practice. Group practice, 2 docs working 3 days a week. I kind of just shuffled around the numbers, and 1 working 4, an extra $200,000 a year. Guys, this isn't worth going. This is too risky, right? So using that same group practice, and then I'm being a little more conservative. I'm like let's just say 70% of your people qualify, and maybe 30% are acute problems and not returning, but 70% returned, $173,000. I mean, we just can't leave that there. I got a question. What about telehealth visits? Yes. And we do have a slide on telehealth because there's an interesting twist. Doesn't make sense, and not for us to debate too much, but yes, if the visit is telehealth, you still are allowed to do the G2211. The thing we need to think about with the Medicare ones with the telehealth is, remember, Medicare telehealth on those codes, 99202 through 99215, require the audio video version of that to bill that code. So that's when you would have that G2211. But I'm going to show you some really kind of a funny note as we look at how Medicare put that on their telehealth approved list. So when we get there, for the person who answered that, you're going to love that slide. All right. All right. When not to bill. Now, there are reasons not to bill the G2211. And this is the reason that we always say, just be careful. Sometimes when a new code comes out, you'll have somebody who's really aggressive and go, I put it on every patient of mine. Every patient is complex. I feel like sometimes if I had a nickel for every time a provider told me that every single one of their patients are difficult and complex, I'd probably be really well off right now. But you just need to apply common sense. And hopefully we're giving that to you here. So, the first box here, we kind of will say, provider's not going to be managing ongoing care. Usually they do, but maybe it's not of a complex or chronic condition, or it's not something for a long period of time where a physician feels like they don't have that kind of relationship. Because remember, we do have healthy patients. We have healthy patients who just need to come to us when they have a cold, when they have a sinus infection, when they have a sprained ankle, when they get a laceration. They're still a long-term patient, right? They've been my patient for 10 years, but they've been really healthy. That really wouldn't be a G2211. Really, because you think about the ongoing piece, the managing piece of this, the time we're spending, the reason they put the code out there doesn't make sense for those types of patients. So you really want to be careful there. Consulting providers, urgent care, but one time I gave this webinar and somebody had a really good point. Their urgent care provider was their primary care provider. That's where they went. They liked their urgent care. The urgent care let them come in and out. They had established a relationship. So again, we don't have absolutes here. We want to be careful about saying an absolute, always, never. And anyone who's in healthcare, you can't say always, you can't say never. get yourself in trouble. But in these instances, we're just trying to give you ideas of that might not be a good idea to add the 2211. And there's one other context out there. Now, reason being, I don't really like it, just doesn't resonate with me why they chose this, because the doc still has a longitudinal relationship. But in this case, what they're saying is if your provider does a procedure on the same day and uses or needs to use a 25 modifier on the E&M code, let's say they came in for earwax removal. Well, we all know if you do 99212 or 3 and the 69210 earwax and you're putting a 25, even if that patient has a long-term relationship, Medicare is saying, no, you can't bill it that day. So, pardon me, why? I don't really know, or I don't know the thought behind that. But just know if you have that scenario, you will have to take off the G2211. And the ideas and tips that I've gotten from other providers using this is that a provider will select saying, yes, this is a longitudinal relationship in the documentation, but there's an edit built in your system. You can set a lot of times with, what do you call them? Scrubbing edits. You can set if there's a 25 modifier, drop the G2211 off the claim and things like that. So that's really a tip there, because we don't want the provider to try. I mean, listen, they can't all know every single rule. So trying to get them to understand, well, if you're doing a procedure, we're going to have to put a 25 on it, and you might as well build it on the scrubbing end and let them define their longitudinal relationship with the patient. All right. Now, what about the documentation piece? We've got some ideas, but I do want to give you exactly what your MedLearn Matters says, because that's important. Because we could do a Sonda says all the time, all day long. But the reality here is you need to document medical necessity for the E&M visit. That's a given, right? Because they want to make sure that you understand that you still have to have a visit. The visit itself still needs to be medically necessary. And that is our usual documentation that we look at E&Ms to say, yes, this was medically necessary or not, or wasn't documented appropriately or not. But the crux of the E&M needs to be medically necessary. And then the documentation also kind of weighs in there. Now, here's exact words from CMS. We haven't required additional documentation. Now, I'm going to tell you, being the compliance queen that I am, I'm not going to rest on that. I understand what they're saying. What they're saying is they're not going to give you language. They're not going to try to tell you. They're trying to explain to you what the definition of the code is. And it would be, if they literally gave you words, that's all they would see in the notes. So they want to give you context. They want your words, right? They want your words to describe it. So they're saying our medical reviewers, and they're putting this out there already. So when you see this, our medical reviewers may use the medical record documentation to confirm medical necessity and the accuracy of the documentation, the time you spent. They're just talking about, if the documentation is there, you're going to be fine. How will we look at that? We might look at records. They go a little bit further, right? So I think we need to look at that too. They're saying, well, somebody asked, what do you think you'd look for? Well, we might look for claims history. So remember, everybody, I don't know if you know the terminology, but there's a lot of this going out there, data mining. Insurance carriers have the ability to data mine, in that they can take G2211, correlate it to a patient, go back through claims history, look for corresponding. I mean, they could build an algorithm that could flag providers before you even know it, right? They could build the algorithm for, is there any type of condition here? Is there this condition been seen over a period of time? How often was this patient seen for this? We're not being told what the criteria is, but they're saying we could look in the medical record, we can look in claims history. I'm going to tell you, they're going to look at the assessment and plan. This is what we do as auditors, right? The assessment and plan right now, since 2021 and the changes to the documentation of the E&Ms, the assessment plan is so, so important. And that's where we go with our providers saying, the assessment here has to be this. Tell me what you were seeing the patient for today. What are the statuses of those conditions, right? Because a lot of times they just go hypertension, continue on lodipine at 10 milligram, blah, 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 blah. And you're like, okay, but what is it today? Is it stable? Is it under control? We want to see something like this. Hypertension. Patient has been compliant with medication, maybe a couple home, he might say the home values or the measures have been within compliance. We're going to stay on the amlodipine, no changes at this time. Or they might say hypertension, not at goal. Patients' hypertensive or high blood pressure readings have been more than not outside of our agreed upon plan. Therefore, although no changes are necessary in this medication, we need to watch over this. That's where we're saying the value is. We want them to tell us in their assessment, what are you assessing today? Not that you have this laundry list of problems. So I never want a provider to feel like they have to list a laundry list of, he has diabetes, he has hypertension, he has hyperlipidemia. Now, if they're addressing all of these today, I get it. Well, if you are, then I need to know. This one's in compliance. This one isn't in compliance. These are all stable. The medications are working. That's where the value is. And so that's what I want to tell you that Medicare will be looking at too. And then, of course, they look for other service codes that are billed and that you have documentation. But then let's say, okay, well, all of that's there. What else might work? I do believe there's like things you can do. It's best practice. So I mean, don't scratch your head. I don't want anyone to feel like, well, CMS said I don't need anything for G2211. I just need my E&M has to be medically necessary. You know what? I'm going to tell you my opinion. I'd put something in there. I would put something in there that the provider, it's sort of an attestation from the provider saying, if you can't read in my note, I have a relationship with this patient. I am taking care of them. I am managing these problems. So we kind of just threw some together here. And when I say threw some together, that's how we did it. And I don't want you to have to take these word for word. This is just kind of giving you ideas. Ongoing care for, maybe they have MS. Ongoing care for the MS due to my longitudinal relationship with this patient. This visit required additional cognitive effort and maybe that's too much. Don't know. Managing this person's hypertension required extra effort due to coordinate and oversee the patient's overall care because they have not been in compliance. You always start with a macro. It's like giving your provider, it's like I don't have writer's block here. We're going to start it for you, but don't leave it like that. That is the only problem with macros that I see. So I'm going to caution you. You got to train. You can put a macro out there. It can cover these things. But if we're not paying attention to the fact that they're being updated, so when you do auditing, your proactive auditing and monitoring, you got to make sure that your providers are putting in the words, putting a little extra. I see good and bad in this and documentation with everything else. So here's a couple of them. We also provided some in the policy. So at this point, like I said, they still haven't really given us anything more than that. You just need clarity. Sometimes you'll find it in the past medical history. Sometimes you won't. It depends on your structure of what your evaluation and management looks like. It's always tough for auditors. We do like to say, please don't have 15 pages for a 15-minute encounter. It's all should be very succinct, very clear. And if we can build macros, that helps our provider not have to type everything. But we do want, like, if you have a great system where it's designed when they go, okay, sometimes it's called smart keys. They can do like Control G. Let's say we call it Control G, and it starts with the macro. Make their cursor go right to the end so they can put some words in. That's all I'm saying is we just have to be solid about it, how we approach it. and how we train our providers up on actually using it. All right. Here's the one that is going to be really interesting. So thanks for the question about the telehealth. Let's kind of unpack this. So G2211, if you bring up the most recent CMS telehealth approved list, G2211 comes up on there. But here, look at that right-hand side. So interesting, right? So 99202 through 99215. Look at where it says, can audio only interaction meet the requirements? No. And we know that's a no. Any of us who work with Medicare know that if it's audio only, we have to divert to the telephone only codes. But look what happened. The G2211 got labeled with a yes. Now that, guys, right? Things happen. That does not make sense. We have to use our smarts when it comes to this, because we can't put G2211 with the 99, what is it? I can't even think of the numbers right now. It's escaping me. But the 441, 442, 453, I think it is. But we can't put G2211 with those telephone only. So I don't know why you can't bill 2211 by itself. So there's no way that we can use audio level and bill a 2211. So I think this was just a mistake, and likely they'll correct it. But you remember, it's an add-on to our 99202. You are allowed to use it in a telehealth manner. So if that call was about their care and it was done via audio video, you can add the 2211. So hopefully that clears that up a little. But I thought it was kind of funny that they say, yes, you can do audio only. These are just mistakes. We all make mistakes. All right. But let's just be careful, right? I think this is me being putting my little compliance hat on, is I don't want you to get in trouble, and we don't want to put you in a situation where money is being recouped. So, use common sense and build the guardrails, in your organizations that work. And you need your doctors your docs, your nurse practitioners, your PAs to all get together as a group. If you're in a group scenario, they should all decide together, this is when we're using it, this is when we won't, or, give that, kind of put that around it, and then get them to agree so that you have some, I'd say, that you have a core. There's going to be scenarios that you can't put into a policy, and we're going to have to lean on their judgment. And the only way then to check on it is do the monitoring and the auditing follow-up. So there was a provider that was coming out and saying, oh, this is fine. Now we have a code. Thank you, Medicare. You're finally recognizing it. Well, I'm going to put it on every patient. That's just bad advice. Okay. If a consultant gives you that advice, run away, even if the consultant is a physician. But really, you just, again, let's use common sense. Let's not, we don't want to debate it so much that we get so worried about the risk. We're like, it's not worth it for us to sweat a recoup. No. You just develop the policy. It's a new code. It's valid, and we can do it. So with new patients, if there's an expectation that they think they're going to have this long-term care, so that would mean to me, and I'm just guessing, and we can all kind of put our thoughts on this. I have a sinus infection, I don't have a provider, so I'm going to establish care. Really, it's really hard to do that anymore these days. Trying to get in with a primary care within a week, within a couple days, is almost near impossible. So it's not that you'll get this many, but generally speaking, if a patient's coming in for an acute problem and they're generally healthy, I wouldn't recommend adding G2211. But if the patient comes in and they're like sinus infection and they go, oh, doc, but I've had hypertension, I've been on meds, I'm not taking them now, I'm trying to do it with diet and exercise. This establishes a relationship and a pattern that patient is expected to come back, and we're probably going to follow them. So in that case, same presentation of sinus infection, but we've got some underlying things here. The patient's just kind of regurgitating, yeah, well, I used to take meds, and I'm in the 140 over 90, This is where we're going to establish that relationship, and it might be okay. And that's why you do have to train your providers. There were some other frequently asked questions with some MACs. It's kind of nice when you're trying to put guardrails around things when these Medicare administrative contractors come in and give us something. And they said, it can be used for a new patient when it's expected that there's going to be additional visits. We're going to need to treat them. We're not just, going to bring them in, give them amoxicillin or whatever, and then send them on their way. So be careful. And obviously, anytime the modifier 25 is on, please don't mess up your claim because you definitely don't want that to happen to you. All right. So let's just quickly in our last, I think we got like 15 minutes here. And if you've seen the MedLearn Matters, you've seen these before. But let's just go over them real quick so that you know that what they were actually given. Patient sees you, their primary care for sinus congestion. You may suggest conservative treatment or antibiotics. You decide on the course of action, best recommendations. This is also how you can continue to help them meet their primary health needs. So what their answer was to that, that when all consultants look at this, they were like, wait, what? What do you mean when there's a sinus congestion? That doesn't fit my theory of serious, complex. So really, when we think about this, we're thinking about not the presentation at the current moment. So that's what they're saying. It doesn't capture that specific clinical condition. It's capturing the relationship and the management of it behind the scenes. So I might have an acute problem. I might be seeing them for COVID, but because I have COPD or asthma, that really is a big problem. And we're managing that in the background. And the provider's probably not just going to go, you got a little bit of a, cold going on here. They're really going to give it some thought. And that's where that relationship comes in. So real quick, can this code be used for orthopedics? Well, the straight answer for that is yes. But then the thing is, we have to kind of vet out examples. Is the orthopedic seeing the patient in a context with a long-term condition that might be muscular or bone related versus a patient where they would only be taking care of like surgery? Some of them, like, let's take hip replacement. Okay, maybe, yeah. It depends on how long that orthopedic is seeing that patient and what that longitudinal relationship looks like. I wouldn't want to stretch this to say, oh, well, I see them like once a year. Well, maybe once a year. We could debate that as well. But think about it from the perspective of what is it that specialist is managing? How are they managing it? And does it make sense for them to get the additional relationship type of payment in addition to their E&M? Have you seen this code being paid in pediatric primary care? Yes. And in this case, we have kids with problems, right? For sure. You have kids that have medical problems. We have kids that have things like ADHD. This is serious. This could get in their way of actually education, in their way of socializing, in their way of actually getting better. There are many reasons pediatrics use it. The only theory here with pediatrics is you maybe have a smaller subset, right? So the examples we gave as potential increase in revenue may not resonate with pediatrics exactly. But again, if it's $15 extra, if it's these children that you have relationships with the family and you're managing these pediatric conditions, absolutely. Let's not just carve out because they're pediatrics and don't see much Medicare. If we have our carriers actually looking and paying for this, so we definitely want to do it. All right. Example number 2. Let's see there we go. And this one makes sense, right? We don't even need to debate this one. This is patient has HIV. They're there. When you manage HIV and one of our clients is an HIV specialty clinic, this is an ongoing relationship. This is an ongoing relationship for many, many, many reasons. They might even have a, what we say, they don't necessarily have full-blown AIDS, but they have that problem where it's asymptomatic, but the relationship is there. the management is there. And it's definite that that made sense when they put that in there. So let's kind of look at it from this perspective real quick. And I might go a little faster because I want to respect your time. We've got about 10 minutes. You want to create your policy. We've done that for you. So we've given you a little leg up for coming in today that you get to access that document and you can alter it as you see fit to work within your practice. You just want to talk about conditions. Since there's ambiguity, a nice place to start is in the moderate decision making. When you're working with your providers and they know the medical decision making chart, you can say, let's start here. And this is just a starting point to say, well, if they have one or more chronic conditions, probably they might qualify. They have two or more stables. They have an undiagnosed new problem, which may establish a new problem. Like, for example, lump found on the breast. This is going to be a long-term thing where the patient was healthy. And now I have to have that. And that might be a good thing for GYN, right? I'm a GYN. I don't really have a lot of chronic conditions. Well, when you're dealing with your patient who unfortunately is going through breast cancer and you're going to be seeing them, it's definitely going to be the relationship thing going on there. An acute illness with systemic, well, questionable, right? Maybe there's a time period, but I think we're looking more on the chronic side. We're just trying to give you, where do you start with your providers? Where does the conversation start? It generally starts with the chronics. And the reason the chronic is because it lasts a really long period of time. Acute and complicated injury, we'll probably leave that one to the side anyway. But like I said, we're developing guardrails. We want to stay safe in the way that we work with our providers. And here's the one I wanted to tell you about in terms of what do we see with the policies out there. Now, I do have some bad news. Don't make this shadow over trying to build this code. The bad news is United Healthcare has come out and said, beginning September 1st, they're now going to say the G2211 is rolled into the E&M. You know, they say it's an inherent part of the evaluation of management. So that's going to go away. But very important, don't stop billing it. Okay. Why is that important? You have to, whenever you're managing your rev cycle, and this is what I was kind of talking about a couple slides back, is that you need to be aware of your United Healthcare because there's 3 policies inside there. There's 100, but 3 main, right? Medicare policy, commercial policy, and a Medicaid policy. This is only affecting commercial. They're not taking it away from the Medicare Advantage plan. So we want to make sure it's same thing with Anthem. You see down there, Anthem, Blue Cross Blue Shield, starting 8/1. So if you started to get rejects, unfortunately, this is the policy that came out. It went into the bundled code list. Why do they do this? Gosh, that for me is a long, drawn out conversation. I do get dissuaded, kind of discouraged when policies do this, but they're trying to cut costs. That's my guess. I don't know why a person with a commercial based policy can have the same chronic conditions as someone with a Medicare. But remember, same thing with Anthem. We have Anthem Senior Advantage. We'll still pay for this. So think about it from that perspective. If you're not tracking your rev cycle by those main types of policies, this would be a good time to do it to make sure that you are getting paid when it is a Medicare Advantage policy. All right. With that, this is basically our last slide, and we'll take any questions. So if you have a burning question and you want to pop it in the thing or tag Gina, that's great. The only official guidance you have to go by is CMS, right? That's official. That's the MedLearn Matters. That's everything. And that's the correlation to the link that's here on this particular slide on how to use it. From that, you develop realistic goals for your providers to build this, and then you just monitor it. And if you feel that your providers are using it wrong, you have that open conversation. You go back. I just feel like when people kind of step back and say, that's too risky, then you're leaving revenue on the table. And in these days, we just can't do that. Do we have anybody have any questions, any thought provoking from all the slides that we just looked at and talked about?
This has been great, Sonda. So that link that you have on the screen obviously will be in the PDF, but we'll also include it in the email so that people have easy access to it. There was a question about they're a urology office and they want to
Okay.
know if the codes will work for them.
Yeah. So again, great question, and I love it. So let's talk urology for a minute. There are definitely reasons why a patient will frequent a urology office. I don't want to say I'm an absolute pro urology, but think about the relationship and how often you might see a patient. Some patients come to urology and it's to fix something. It's to, you know, whatever the case may be. Maybe it's to have a procedure. They were referred. But honestly, when you think about the patients that are seeing your urology for a condition, a problem, you are allowed to build this. If it's a relationship between the urologist and the patient, and they're coming back throughout the year, and there's no context in the G2211 of how many times you have to see them, you are their single source for that problem. So that patient, same patient seeing their urologist who sees the primary care may be billing G2211 for his relationship. Urologist can too, if there's truly a relationship. So that's where you got to put the value, not necessarily the type of specialty, but what is that relationship? And again, if I were a little smarter on urology, I probably could come up with a few, but you definitely just want to test the relationship and the condition that the provider is seeing them. Let's say they see them 3 times a year. That's reasonable. If they're managing a focal point problem for urology, I agree, you could.
So there have been several questions, specialty specific. You answered the one about orthopedics. There was one about primary care, our pediatric primary care. Have you seen this code being used in that specialty? And also,
Yeah.
A question about why behavioral health can't bill.
Oh, so great. Thank you for asking the question about behavioral health, because my love of life and passion is behavioral health. I was only speaking to the context of a LISW and LPCC because they don't bill E&Ms. Your psychiatry, absolutely. Mental health, behavioral health problems, this is a relationship. So thank you for clarifying that. We were only saying who can bill for this service. We just wanted to be clear that it's not something we can add to psychotherapy. It's not something anyone who isn't billing an E&M. But absolutely for psychiatry, when you build that relationship with a patient from a psychiatry point of view, you will add this onto your E&Ms when you're doing med management. So absolutely. For the pediatric, just a little bit to go back to that, we talk about patients who have ADHD. We talk about in peds, people have chronic conditions, babies have chronic conditions, adolescents have them. So we're absolutely there's no what do I want to say, prohibits to any specialty. You think about that relationship. So the best thing to do with peds is say, all right, let's talk, docs and nurse practitioners. What is it we're seeing? Maybe it's ADHD. Maybe it's, a juvenile arthritis. What is the relationship there and the problem? I think that I want you to be careful in peds to say that you do a lot of wellness when they're babies and keeping them. That's not what that's for. This is, more or less managing, because I guess the best way to say this is managing problems. So the wellness piece for the pediatrics sort of stays out of it, but you're going to have pediatric patients who have issues, and that you're going to have to add on E&Ms for that. And ADHD as a behavioral thing is one that I can think of.
Great. There's one question, if we can squeeze it in the next 45 seconds or so. Hopefully you understand this more than I do. What if you bill incident 2 is the question.
Great. This is the great question. This is addressed on the frequently asked questions that's coming out from CMS. And this is like, we have a group of, let's say we have a group of providers. We have some of our MDs and DOs, and then we have our nurse practitioners working under them. Remember, the nurse practitioner is working in a team, or the PA is working in that team. The relationship inherently as a group could be seen by Medicare as a relationship with the organization. And the fact that in Incident 2, remember in Incident 2, we're supposed to be following the care plan of the provider who developed it. We're not seeing them. We cannot do it in a new problem or new condition or anything like that. So that's the continuum of care. So yes, if you pull that And I'll make sure you get that, Gina. The FAQs, it is addressed in that by Medicare. So it's a great question. But the answer is that they are looking at that as a team effort, and they're okay with that.
Great. Well, we are at the top of the hour. And what a great webinar, and filled with such great information, Sonda. We really appreciate you being our expert speaker today. And just to close, everyone on this webinar right now will receive a follow-up email with the recording, as well as some handouts as well. Thank you, everybody, for your time today. We really appreciate it. Have a great afternoon.